How much of a condyle actually needs to be drilled to safely access an anterior foramen magnum meningioma? In this video, we review the key anatomical landmarks of the lateral transcondylar approach and demonstrate how progressive development of the corridors around the vertebral artery, lower cranial nerves, and upper cervical nerve roots provides safe access to the ventral cranial cervical junction. The patient is a woman in her 70s who presented with dysphagia and myelopathy. MRI demonstrates foramen magnum meningioma arising from the lower clavicle dura. A lateral transcondylar approach is selected for tumor resection. The patient is positioned on a 3/4 part bench. A hockey stick incision is performed with the lateral limb centered over the mastoid and the medial limb extending towards the inion. After elevating the skip flap, the muscular layers are exposed. Although the individual muscle layers can be identified in this anatomical dissection, we prefer to mobilize the myofascial flap as a single layer to simplify closure and minimize the risk of cerebrospinal fluid leakage. This maneuver allows for sufficient exposure of the occipital bone and posterior arch of C1. We next identify the condylary emissary vein, an important landmark for locating the venous plexus surrounding the vertebral artery. In this cadaveric dissection, we can better appreciate how the identification of the emissary vein facilitates coagulation and mobilization of the venous plexus, progressively exposing the vertebral artery up to the transverse foramen. Using SAR microsurgical dissection, the vertebral artery is fully skeletonized. Here we can appreciate the difference once the venous plexus has been completely dissected, allowing improved visualization of the occipital condyle. The vertebral artery remains completely identified and protected through the exposure. Another important step to improve condylar exposure is the removal of the posterior arch of C1 and opening of the foramen magnum. The posterior arch of C1 is then removed using a high-speed drill. This maneuver is particularly useful for low-lying anterior foramen magnum meningiomas, such as this one. We then complete a modified retrosigmoid craniotomy, exposing the sigmoid sinus down to the level of the foramen magnum. And once the foramen magnum is open, the occipital condyle becomes clearly visible. In this anatomical specimen, we can better appreciate the relationship between the occipital condyle, the vertebral artery, lower cranial nerves, and upper cervical nerve roots. We proceed with the extradural drilling of the occipital condyle. In most cases, removal of approximately 1/3 of the condyle is sufficient. We also favor limited drilling of the jugular tubercle, which significantly increases the superior working angle and visualization of lower cranial nerves. Once the bony exposure is complete, a J-shaped dural opening is performed. Cerebrospinal fluid is released to facilitate relaxation of the cervicomedullary junction. This cadaveric specimen illustrates the relevant intradural anatomy. Here we identify the lower cranial nerves, vertebral artery, pica, and C1 nerve roots. Given the location of this lesion, our operative corridor is developed primarily between the accessory nerve and C1 nerve root. The dentate ligament is identified here and sectioned. This maneuver facilitates the identification of the accessory nerve, C1 root, and tumor base, while allowing limited mobilization of the cervicomedullary junction. Here, an important remark how we perform the mobilization of the neurovascular bundle using a small cottonoid, using contratraction technique. Arachnoid dissection is continued until the tumor attachment is identified and separated from the surrounding neurovascular structures. We then begin coagulation of the dural base, progressively devascularizing the lesion. It's important here to avoid the temptation of continue the tumor manipulation without initiating some tumor debulking, as this can impact into the brainstem and upper spinal cord, causing severe neurological deficits. Following initial devascularization, internal decompression is performed using this ultrasonic aspiration with preferentially a varicose tip. Because of the dense fibrous consistence of the meningioma, ultrasonic aspiration is only partially effective and repeated debulking is required throughout the procedure. As the tumor volume decreases, the superior pole is progressively mobilized into the corridor between the accessory nerve and C1 nerve root, providing safer access for further dissection. Additional debulking allows identification of the relationship between the tumor, vertebral artery, and hypoglossal nerve, which course anterior to the artery. Sharp microsurgical dissection is then used to separate the tumor from the dorsal aspect of the vertebral artery, and further dissection reveals an additional tumor component extending anterior to the vessel. Once the tumor is completely free from the vertebral artery adventitia, it can be progressively mobilized using a number 4 Youssef dissector. Additional debulking allows delivery of the superior capsule into the operative field. For the vast majority of foramen magnum meningioma, there is no infiltration of the brainstem, which facilitates the mobilization of the tumor capsule, even in the most anterior aspect. The superior pole is removed using pituitary rongeurs with continuous coagulation and sharp dissection. Complete the vascularization of the remaining attachment. Notice how the tumor itself creates a natural corridor away from the cervicomedullary junction. As a result, fixed retraction is unnecessary, and the lesion can be progressively separated from the neural structure through preservation of the arachnoplane. Attention is then directed to the inferior pole of the tumor, and using the same Youssef number 4 dissector, we can mobilize the inferior pole of the tumor into the surgical cavity. Sharp dissection with angle microscissors allow division of the final dural attachment and completion of the resection on the most anterior aspect of the tumor. Gross tumor removal is achieved, and the dural base is coagulated without resecting the dural implantation. The lower coronary nerves, distal pecca branches, and vertebral artery remains anatomically preserved. The dura is then reconstructed in a watertight fashion using bovine pericardial graft to reduce tension across the suture. Post-operative MRI demonstrates complete tumor removal without evidence of residual disease. A Simpson grade 2 is achieved. The patient experienced complete resolution of her dysphagia, and she was discharged at home on post-operative day 2. Once again, thanks for watching, and please subscribe for more scalp-based and cerebrovascular surgery videos. Have a nice weekend.